So in this section we are going to discuss T cell disorders in our immunodeficiency section. So we have read about thymus, structure of thymus, and structure of spleen and structure of lymph node, and now we are discussing disorders of T cell disorder. T cell disorders. In our T cell disorder, we have four categories. Number one is absent of thymus development, which is known as thymic aplasia. Number two is interleukin 12 receptor deficiency, which is present on a naive T cell. And then we have a Job syndrome, hyper IgE syndrome, and then chronic mucocutaneous candidiasis. So first one is thymic aplasia. It means that absent of thymus gland, which can lead to CXR, no thymic shadow. If we don't have thymus, we don't have T cells. So we have what is the pathophysiology behind this? There is a chromosome number 22q11 position. We have micro deletion, which can lead to defective neural crest cell migration, and this migration is very important in the development of third and fourth pharyngeal pouches. These two pharyngeal pouches can form a thymus gland and parathyroid gland, but if the pathway is disturbed, then we cannot form thymus and parathyroid gland. So this is a pathophysiology, and then we have the presentation. In our presentation we have a mnemonic known as catch 22. 22 we have discussed 22 factor, 22 mnemonic, which is the actual pathophysiology. Then we have CATCH. So catch 22, C for conotruncal abnormalities in our CBS system, and this conotruncal part can form truncus arteriosus. This abnormality can lead to tetralogy of Fowlett and aortic arch abnormalities. So when we have a thymic issue, we have a cardiovascular congenital heart diseases or cardiovascular disorders. Then we have AA for abnormal faces. Abnormal faces due to abnormal formation of pharyngeal pouches and due to the hormonal effects of PTH, absence of PTH and absence of calcium. Then we have thymus, T for thymus hypoplasia, T for T cell, T for thymus hypoplastic or absent, which can lead to T cell deficiency. And we have the viral, which leads to viral and fungal infection, recurrent viral and fungal infection. Then another C. Then we have H, hypocalcemia. Hypocalcemia is due to absence of parathyroid gland, and this absence of parathyroid gland, it cannot sense the hypocalcemia hypocalcemia of the body. Decrease calcium, decrease PTH, which leads to tetany. Decreased calcium can cause neuromuscular excitability, which leads to tetany and spasm. and then we have this C, which leads to cleft palate abnormalities. So this is the mnemonic catch-22 thymic aplasia. We have two variants in this category, thymic aplasia. First one is DiGeorge. DiGeorge is actually cardiac, thymic, and parathyroid variant, whereas we have another valocardio-facial variant. Valo means palate problems, cardio means cardiac issues, and facies mean abnormal faces. So this is overall the description of T cell disorder under the category of thymic aplasia. Then we have hyper interleukin 12 receptor deficiency. We have the thymus, we have the T cell, but they don't have, but these T cells lack interleukin 12 receptor. So what does this receptor work actually? This receptor is very much important for the signaling or interaction of macrophages and naive T cell. When a host or a human body is infected with a pathogen known as mycobacterium, which is intracellular pathogen, it infects the bloodstream. So the body's defense against this mycobacterium intracellular pathogen is depend upon its ability, the body's ability to sequester this mycobacterium from the bloodstream into the macrophages. This is the macrophage, and then it directly kills this bacteria into the phagopolisome or macrophage. So when this macrophage goes into the when this mycobacterium goes into the macrophages, it releases a lot of interleukin 12 cytokines. These cytokines goes to the T cell, goes to its interleukin 12 receptor and activate naive T cell into and differentiate this naive T cell into T helper 1 cell. When this happens, the T helper 1 cell releases interferon gamma, which goes to another receptor on the macrophages, interferon gamma receptor, which is a Janus kinase STAT receptor. This interferon gamma translocates into the nucleus and transcribe cytotoxic chemicals, for example TNF alpha, which directly kill this bacteria. So if this receptor is deficient, this whole signal interfered. So when interleukin receptor deficiency happened, then we have disseminated mycobacterial or fungal infection. Patient can also present with post BCG vaccination infection. And in our labs we cannot we have low level of interferon gamma. So actually the treatment is to give exogenous interferons in order to fight with this intracellular microbacterium. Then we have Job syndrome. Job syndrome is also known as it is an autosomal disorder problem, and autosomal dominant. It is a hyper IgE syndrome with normal rest of the immunoglobulins. Job syndrome, autosomal dominant, hyper IgE with normal rest of the immunoglobulins, increase eosinophils. Its mnemonic is A, A for A, B, C, D, E, and F. So the presentation in the job syndrome is atopic dermatitis. Dermatological problem, atopic dermatitis or eczema. So this all categories is under D. A, we have abscesses, which is cold staph abscesses. Then we have A, then we have B. B leads to retained baby teeth. C is the coarse faces. D for dermatological infection. E for hyper IgE levels or increase eosinophils. And F for fractures with a minor trauma. So the pathophysiology of this job syndrome is actually the impairment of the neutrophil recruitment. Neutrophilic recruitment. So neutrophil cannot go to the site of the infection, and it can lead to all this A, B, C, D, E, F a presentation with the increased expression of IgE. Then we have the last one is CMC, chronic mucocutaneous candidiasis. So actually this is a candida infection, candidiasis, candida infection, and it is muco means mucous membranes, mucosa, and cutaneous means skin. So it is an external, so it is a non-invasive mucocutaneous candidiasis. So what is pathophysiology? It is due to the dysfunction of the T cell. Dysfunction of the T cell. This dysfunction, so what is the dysfunction? So actually the dysfunction is autoimmune regulator problem. This autoimmune regulator problem impair the ability of T cell, which can lead to no cell mediated immunity. If there is a no cell mediated immunity, then the body cannot fight with this surface antigens of candida. So there is a persistent or chronic candidiasis. So in our labs we have negative or absent in vitro T cell proliferation in response to candida, and also we have negative T cell response of candida antigen. So this is like the whole T cells disorder. Next we will discuss B cell disorders.